So I'm going to move on and talk a bit about the PreP guideline. Next slide. So like I said, it's important to talk about things that have changed, but also to emphasize what hasn't changed since the 2017 guideline. So there have been no changes to the indications for PreP use. There has been no change in the frequency of follow-up visits for oral PreP. We're going to talk about injectables shortly. And there has been no change in the schedule for HIV and STI testing for oral pre-exposure prophylaxis. So for those of you who don't know, there are 2 oral drugs approved for pre-exposure prophylaxis and now 1 injectable. Their schedules are a bit different, but nothing has changed from the schedule perspective for oral PreP. Next slide, please. This is a really important new part of our guideline. There is a new recommendation that's really designed to increase awareness of PreP within the primary care and other environments. The new recommendation is that all sexually active adult and adolescent patients should receive information about PreP. So there's a lot of reasons why we're doing this. It encourages providers to offer PreP as a core primary care service and reduces missed opportunities for PreP provision. We're trying to do better of embedding this into the fabric of primary care service. It also increases knowledge of PreP among potential users. So that allows for people to either immediately decide if they want to go on pre-exposure prophylaxis or have awareness of scenarios where it may benefit them to go on PreP if there are changes in their sexual or drug using lives. Also, it increases knowledge of PreP in the community. So a lot of us walk around and really spread the word about PreP no matter where we are, whether it's in an Uber or among friends. So we think that there's definitely something to be said for the person-to-person interaction that happens. So the idea that more people learn about PreP means that more people can actually share PreP and the idea of pre-exposure prophylaxis to others, whether they're family, friends, or acquaintances. Next slide, please. So I want to talk briefly about the daily oral pre-exposure protocol. And this really focuses on prescribing and lab testing. So we'll start with that first column and talk about the PreP initiation visit. So for daily oral pre-exposure prophylaxis, it starts with an HIV test. And that ideally is an HIV antigen antibody combo test that's performed in the laboratory. I'll also mention that there are same-day start options described in the guideline as well, which I'll refer you to. In terms of kidney function, it's important to check kidney function when starting daily oral PreP. And really, depending on kidney function, will be different recommendations for what drug to start. So if someone's kidney function estimated creatinine clearance is greater than 60 mils per minute, you can start a TDF-based regimen, also known as Truvada and the generics, or a TAF-based regimen, which is also known as Descovy, no generic available yet. If there is a renal function that's lower but greater than 30 mils per min, then Descovy or TAF FTC becomes the option. There also needs to be screening for STIs, and it depends on the population what you do, but syphilis, gonorrhea, chlamydia are among the tests to order. There is a recommendation for a lipid screening, not for TDF or Truvada and other generics, but for Descovy because of some possibility of increased lipids in the future. A need for a hepatitis B serology, and then a prescription for 90 days. Follow-up visits for oral pre-exposure prophylaxis happens every 3 months. And there is a change in the guideline here. The recommendation is to order a HIV antigen antibody test, again, ideally a lab-based test, but to supplement that with a qualitative RNA. So another test to look for direct viral detection. And that is really because there is a disconnect in some studies between time of seroconversion on the serologic test and when virus becomes detectable. So it is really to have a zero tolerance for missed HIV infections in follow-up. From the kidney perspective, another important change, if people are over 50 or have a creatinine clearance that's less than 90, they should get their kidney function rechecked every 6 months. If, however, they're under 50 or they have a kidney function that is over 90, they can get their kidney function checked every 12 months. So that's a change. It used to be everyone was getting checked every 6 months. Again, on follow-up visits, there are STI recommendations that really focus on specific populations. For people who are on Descovy or the TAF-based regimen, you have to repeat lipids every 12 months, which is very much in line with good primary care anyway. And then also at that point on the follow-up visits, another 90-day refill is prescribed for follow-up. Next slide, please. We also have another PreP dosing regimen. It's often called 2-1-1 or event-driven PreP. So this is a regimen that is not recommended by the guideline, but we give the roadmap for how to do this in case there is a population or group for which it makes sense or an individual for which it makes sense. So this dosing regimen is not FDA approved. This is an off-label schedule for offering oral pre-exposure prophylaxis. Event-driven PreP is only for adult men who have sex with men, so other gay, bisexual men and transgender women who request non-daily dosing, have sex infrequently, so less often than once a week, and are able to anticipate sex or delay it to permit for the 2-1-1 dosing strategy. And in case you can't see that slide very well, what that means is 2 to 24 hours before sex, take 2 doses of TDF-based PreP, so that's the Truvada or equivalent generics. Sex happens, and then 2 more days of daily PreP after. So it is 2-1-1. The way that we recommend that you do this is that you prescribe TDF-based regimen, whether it is Truvada or the generics, with a 30-day supply and have that happen before the next HIV test. And also, it's really important to have a conversation about how to safely switch between daily and 2-1-1 dosing. And that is all very clearly described in the guidelines. So I refer you to that for more detail. Next slide, please. So now I'm going to talk a little bit about the new injectable PreP, also known as cabotegravir or Apretude as a brand name. So in the initiation visit, there's a little bit of a difference. In this one, it's not just an antigen antibody test. There is also a qualitative or quantitative viral load or RNA that's done at that time. And the reason is that you really want to rule out acute HIV infection before you give someone a drug that has an extraordinarily long half-life. And so it's really making sure that the screening is complete, that they do not have an undetected acute infection, and then that should be the initiation of the medicine. STI screening is also included, and you'll see a couple of things have fallen off. There's nothing about lipids here. There's nothing about kidney function because they're not necessary for cabotegravir. Provide cabotegravir injection at the initiation time, which is ideally after you know that their viral load and HIV test is negative, and then again 1 month later. So it's the first is start it, come back in a month for your other injection. Subsequently, it moves to every 2 months. And the follow-up visits, again, include an antigen antibody test, as well as a qualitative or quantitative RNA, so another viral load test. You will also do STI screening. This is going to be every 4 months. So since people are coming back every 2, the schedule is a little bit different than the oral. You're not going to do STI testing every 2 months. You're going to do it pretty much on every other visit. And then provide cabotegravir. And as I said, after that first 2 months where it is a monthly dose, it moves on to an every 2 month dose. And that, of course, depends on dosing if the HIV test is negative.